This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from Neurology India 2026 titled Effect of Pharmacological Neuroprotection During Surgical Clipping of Anterior Circulation Intracranial Aneurysm on Neurological Outcome, a randomized controlled study.
This is a topic that hits home for anyone who spends time in the subarachnoid space. When we're dealing with anterior circulation aneurysms, whether it's an ACOM, an MCA, or an ICA terminus, the use of a temporary clip is often an essential maneuver. It softens the aneurysm dome and gives us that control we need for safe dissection. But as we all know, that control comes with a price tag, the risk of cerebral ischemia.
Exactly, Dr. Aris. The paper points out that this risk of ischemia is the primary adverse event we're trying to navigate. Traditionally, there have been two main philosophical camps for preventing this. One is more reactive, detecting ischemia using somatosensory evoked potentials, or SSEPs, of the relevant arterial territorial distribution, and then taking corrective measures.
Right, the wait-and-see approach with electrophysiological monitoring. If the SSEP drops, you pull the clip or increase the blood pressure. But this study focuses on the second camp, preemptive pharmacological neuroprotection.
That's the core of this randomized controlled study. They looked specifically at the effect of using pharmacological agents before the temporary clipping of the parent vessel. The goal here is to induce what we call burst suppression on the EEG.
For our residents listening, let's dive into that mechanism for a second. Why are we aiming for burst suppression? The paper emphasizes that inducing this state is a way to provide neuroprotection during the period of focal ischemia caused by the clip. By essentially quieting the brain's metabolic demand, we hope to widen the safety window before irreversible damage occurs.
And what's interesting about this study is the design. It's a randomized controlled trial, the gold standard, focusing on the preemptive side of things. They wanted to see if this preemptive pharmacological neuroprotection actually translates to a difference in postoperative neurological deficit and overall outcome for patients undergoing anterior circulation surgery.
It's a critical question because in the heat of a complex clipping, you're always balancing the clock. If you know the brain is pharmacologically protected and in burst suppression, does that change the neurological outcome compared to simply relying on SSEP-guided corrective measures?
The authors specifically focused on patients with anterior circulation intracranial aneurysms. These are cases where temporary clipping of the parent vessel is frequently required. By studying the postoperative neurological deficit as their primary outcome, they are looking past the operating room and into the recovery ward to see the real-world impact on the patient.
And that's the key. We can see all the bursts and suppressions we want on the monitor, but if it doesn't reduce the rate of postoperative deficits, we have to question the utility. The study highlights that the usual approaches involve either this preemptive suppression or the SSEP-driven territorial monitoring.
I found the wording regarding SSEP monitoring quite specific. They mentioned detecting ischemia in the relevant arterial territorial distribution. It reminds us that neuroprotection isn't a one-size-fits-all blanket. It has to be tailored to the specific vessel we are temporarily occluding.
Absolutely. If you're on the M1 segment, you're looking at different territorial risks than an A1 or the ICA. This study really pushes us to look at whether preemptively armoring the brain with drugs before that clip goes on is superior to waiting for the SSEPs to tell us there's a problem.
It's a rigorous look at a daily problem in the OR. The fact that it's a randomized controlled trial gives us a lot more confidence in the data regarding postoperative outcomes.
It certainly does. It's studies like this that help us refine our anesthetic and surgical protocols. Instead of relying on anecdotal surgeon's preference, we can move towards evidence-based neuroprotection.
Well, that's all the time we have for this deep dive into the Neurology India study. It's definitely a paper that residents and attendings alike should have on their radar when planning their next anterior circulation case.
Well said, Alara. Thank you for joining us on the Neurosurgery Hub podcast. We'll see you in the next episode.
Goodbye, everyone.